I think we're on, lads.
Rightio. G'day. This is an exciting topic. I'm super excited about being here today. I've got Alex with me, obviously, but we've also got Mark Yazer, who is a bit of a specialist that I met over in Taiwan when I was there recently. So, Mark, thank you for joining us on Pre-Hospital Nerds, and you have got some amazing stuff that we want to talk about. But before we do that, mate, let's talk about your background, mate. I think you've got a couple of letters behind your name or something. Would that be right?
Two, actually. Two. And g'day, guys. G'day, Australia.
Well
Tough luck on the Ashes. I'm sure you'll win them again back in England. You know, it's not like we had anything else to do for 3 days twice. So, you know, better luck at Lord's, the way I see it. But yeah, listen, lads, thanks so much for the invitation. It's a really pleasure to be able to do like an inter-specialty thing where you know, we're all related and we're all doing the same thing, but we're doing different parts of it. And so it's great to be able, for me, to learn from you guys, and if there's something I can help you with, then it's a pleasure. So yeah, those two letters are MD, Mike Dominator, as I like to say, back in high school. But as far as the bank is concerned, that's medical doctor. And yeah, so I'm a professor of pathology. Well, I'm a sports fan, but in the daytime, I'm a professor of pathology at the universities of Pittsburgh, Tel Aviv, southern Denmark, and Albert Einstein in Brazil. And my main job is transfusion medicine and helping out clinicians when something goes wrong with the transfusion, or do they need to transfuse, answering calls. And my research interest is in blood use in life-threatening hemorrhage. And so that's where we come together today. And we need to give a shout out to Wade, our man Wade, the fixer in Taipei, for arranging that meeting where we met. So g'day, Wade. And thanks again.
He was fantastic, wasn't he? He was a great host for us over in Taiwan. And it was amazing listening to you over there, and which is, you know, why we've got you onto the podcast today, because you obviously are very knowledgeable, and I feel very inferior, and I'm sure you do as well, Alex, with that breadth of experience that Mark has behind him. Now, Mark, how many research papers, this is going to make you feel even worse, Alex, how many research papers have you done, Mark?
Well, good ones or just in total?
Doesn't matter, mate, as long as your name's on them.
Maybe about 360 or so.
That's not a bad
360, that's good. Yeah, that's just one a day.
Yeah.
Well, yeah, one a day for a year, and then the other 21 years I've just done nothing. Exactly.
Yeah,
don't tell my boss.
Wow.
Yeah, do you know, we have
a
a good
good ones
environment here in Pittsburgh. We've got a lot of people interested in transfusion, and I've been lucky enough to meet great people like you guys around the world and collaborate. So it's the best part of it. You know, there's only so many febrile transfusion reactions that you can deal with before you kind of, you know, all right, I got that. But with the research, you know, it's new, it's innovative, it keeps you interested, and so that's why I do it.
Wonderful, mate. Wonderful. Alex, do you want to lead with a question, or do you want me to launch into this?
Well, I could just tack on to, we were talking about research, and you've done a lot of papers, but one of the key papers would be that PAMPer trial, isn't it? You were on that.
Yeah.
So that
That's
sort
the
of
one I
sets
would
the
have
scene
said,
a bit for pre-hospital blood transfusions. So if we were to go through this in a sort of chronological order, although that's not the typical format of the podcast, you know, but trying to go through stuff, what would be the first sort of question to address, I guess, is who should get pre-hospital blood? Like, what are the indications?
So the PAMPer trial, for anyone who doesn't know, was a study where really, you know, really germane to what you guys do. We randomized patients who were injured and brought to trauma center by helicopter to get either the standard of care, which could have been red cell or, God forbid, crystalloid, or to get plasma plus the standard of care. And what we showed was that the patients who received plasma had better outcomes than patients who received the standard of care, and that lasted for 30 days. And there was all kinds of really cool secondary analyses, but the most interesting one, I thought, looked at like survival compared to what exactly the patients received. And it turns out that the patients who had plasma plus red cells, so yellow and red minus the platelets, had the best survival. And guess who had the worst survival?
Crystalloids?
Spot on. Foster's for you, Matt.
Yeah,
And
Foster's.
or maybe that's what happens when you get the wrong answer. But,
Correct.
I
Yeah.
think Foster's is given to the people who get the answer correct, isn't it? That's wrong, not correct.
yeah, yeah. Sorry about that. So local microbrew to you.
Yeah,
But
thank you.
yeah, the patients who had the crystalloid, who had liters of basically liquid death, if you will, because it's acidic. It doesn't promote hemostasis. It doesn't carry oxygen. It dilutes, and there's a variety of other things that it does. In particular, end up in the third space. They had the worst survival, and so we've known that for a long time. That wasn't anything new, but showing it once again in the setting of a modern randomized trial where we were using blood products and not just comparing people who had a lot of crystalloid to patients who had a little bit less crystalloid, was a really useful finding. But unfortunately, it still remains, I think, the standard of care, in particular on road ambulances in the U.S. There's only a handful of services that are using blood products on the road. In the air, we kind of have that down. Many air ambulances or helicopters will have blood of some kind, but still standard of care on the road.
Yeah, so that is very true, and I think you find that in Australia as well, that the majority of road-based vehicles won't be carrying blood with them. A lot of them will have the availability to be able to have it brought to a scene, but obviously there's significant delays with actually occurring. So HEMS throughout Australia, most of them carrying blood as far as I'm aware, and being able to access it is the issue. And there's many things that go around it, and that is the governance, the ensuring that it's kept at the right temperatures, the bags and so forth, which we can talk about, and how you carry it around and all the rest of it. Now, so for the people listening in today, we have a range of people from students through to professors. Probably not so many professors listeners to us, Alex, I wouldn't imagine, but certainly through to doctors and so forth. Explain blood products to me, mate. You've mentioned albumin, you've mentioned plasma and platelets and red cells. For some of the students that are coming in and listening to this podcast, can you explain the difference between the different types of blood products?
Yeah, absolutely. So it generally all starts with what we call a whole blood donation. So, you're altruistic enough to go into the Australian Blood Center, or maybe they come to you with a big van, and you make a donation. They ask you a bunch of questions. They put the needle in your arm, and out comes whole blood. And whole blood, it's like whole milk. It's everything that comes out of the cow or the donor. And in this case, it's going to be red cells, plasma, and platelets. And then the whole blood can either stay as whole blood, which is great for trauma patients because you're giving the patient balanced resuscitation, and balance means 1 drop of red cell, plasma, and platelet every time, for every mil that's being infused. And that's really good for patients with life-threatening hemorrhage. The whole blood can also be broken up into its components, so you can make a red cell out of it, plasma, a platelet, and sometimes cryoprecipitate. And doing that is helpful for patients who have like a single problem. So for example, you might have an oncology cancer patient who's a little bit low on platelets, and they don't need a whole blood transfusion because that would be giving them, red cells and plasma that they don't need. But because we've got a platelet sitting in a rotator on a bench, we can just give the patient the specific component that they need. Same thing is true with red cells. There's a lot of patients who are just anemic, and if they can't be medically improved with iron, with erythropoietin, then they can just get a simple red cell transfusion, and that's really great. But again, coming back to our topic, the patients with life-threatening hemorrhage, again, before you know anything about the patient, like when you guys arrive on the scene and the patient's bleeding and hypotensive and tachycardic, high shock index, which is basically the indication for transfusion. Matt, or Alex, you asked me that earlier. That's basically one of the best things we can do pre-hospital if we don't have easy way to measure. If you don't have an easy way to measure lactate or hemoglobin, you use vital signs. And frankly, I think, when you see a patient with life-threatening hemorrhage, you know it. You're just going to see it. And it's like a certain kind of art form that people talk about. It's hard to describe what it is, but you know it when you see it. And the shock index can help. But so those patients, you don't know anything about them. You don't know, are they hyperfibrinogenemic? Are they in shutdown? Are they fibrinolysing? Are they thrombocytopenic? What's their platelet function? So for these patients, pre-hospital and before you start getting some laboratory testing back in the hospital, whole blood is like, it's the thing for these patients, because you're guaranteed to give a balanced resuscitation in one bag, and it's easy to carry. It's not a lot bigger than a red cell that we already know how to carry, and it provides some platelets. And platelets, because we keep them at room temperature for up to 7 days, they're a really tricky thing to store because you've only got 7 days to use them. And so it's unlikely that a blood center is going to give them to a HEMS base because you might not need them. And then what happens? They get wasted, and that's not great. So many HEMS will go out with either red cells or maybe some plasma, but they won't have platelets. And whole blood gives you a dose of platelets that the patient wouldn't have access to otherwise. And it's true also in, I'm trying to think of like a small remote diving village or some place where tourists might go that's off the beaten path because there's some cool thing to see, but there's danger. And so, imagine if someone gets injured in a diving accident. I was just reading about the shark attacks in Sydney. Imagine someone is, someplace remote and they get bitten by one of those things. You're going to want to give them platelets. So having whole blood there, if you can't have platelets, it's going to advance the care. It's going to give them a fully balanced resuscitation product.
Yeah, that's amazing. Such a good answer.
Yeah, what a great overview. I think, Shep, you asked for something for the students, but there was a lot for me there as well. So, yeah, no, thanks, Mark. That's a great overview. So, we'll talk about whole blood transfusion, I guess, a bit later. Matt's lined up some thoughts around that. But just to summarise, so there's sort of three things there you're saying the blood can do. There's red cells to carry some oxygen, there's platelets to sort of plug a hole, and then there's the plasma with all the clotting factors. So in a trauma patient, what's the biggest problem? Or do they all occur sort of concurrently? Or obviously if you've got a shot wound and you're hosing out of one part of an artery, that needs a lot of platelets and coagulation factors there. But if there's multi-trauma, then is it more important to get some oxygen carrying capacity red cells into them?
Well, that's exactly the problem, Alex, is I don't know. And you don't know when you first get to the scene, because you don't know anything about this patient. Did they start off perfectly healthy? Like, did their hemoglobin start off at 160 and 170? Where they normally have the normal amount of platelets? You don't know a thing about this patient. And so I think it's safe to assume that if they're bleeding whole blood, then replacing the whole blood, it just makes sense, especially pre-hospital when you just don't know. Later in the resuscitation, when you get the thromboelastogram back and you've got some sense of where the patient is, you can provide tailored therapy. As you say, maybe the patient has a problem with the clotting factors, and so they're going to need some extra plasma or some fibrinogen or platelets. But at the beginning, you don't know. And for the sake of a bag that's a little bit bigger than a red cell bag, why not provide plasma and platelets too? The other thing people forget about is in a red cell, there's 100 milliliters of basically saline, adenine, glucose, and mannitol. And that's really great stuff because it keeps a little bit of plasma in the unit liquid so it doesn't make a clot, and it provides food to the red cells so they can be kept for 35 or 42 days. But when you infuse that 100 mLs, that's just regular fluid. Like that doesn't have any oncotic pressure. That fluid is going to go 2/3 extravascular, 1/3 will stay in the vessel, and that's for every red cell you give, 100 mLs of that. So when you give a whole blood transfusion, you're giving about 70 ml. So you're giving less of this additive solution stuff, and you're giving balanced resuscitation. So I think it's a really good product for all of those reasons. And you can leukoreduce it or not leukoreduce it. There's a platelet sparing filter that you can get that doesn't take out as many platelets when you take out the white cells. There's national laws that deal with, does it have to be leukoreduced or not? But I think in that sense you're providing a very balanced, complete resuscitation with less of the other stuff that the patient doesn't really need.
Mate, amazing. Always good to hear. One thing that I love winding you up about is the administration of normal saline, and you have, or crystalloids in general, and you spoke about this during the presentation. Now, I'll put you in the situation where you're an ambulance crew on the road and you go to somebody who's clearly tachycardic, hypotensive, looks very unwell. You are in a remote location, they've been bitten by that nasty shark. We call him Bruce. He's been bitten by Bruce, and he's bleeding a lot, and there's no blood pressure, the mentation's off and so forth. What would you say about giving them normal saline? Because a lot of ambulance guidelines will say give them a crystalloid to support their blood pressure. Are you completely against crystalloids and just going for maintaining carotid pulse, or can we give them a little bit and then wait till the blood arrives? What's your thoughts?
So there's a couple of answers to that. My question back to you would be, what's your goal with giving crystalloid in that situation? Like what is the intended benefit in that situation?
That would be...
Look more like we're doing something. Oh, go ahead.
Making me feel good.
Yeah. You got to do something.
Yeah, maybe you think that it's going to elevate the blood pressure a little bit. Well, we know that permissive hypotension is fine. We know that patients who arrive at a hospital with a systolic between 100 to 110 don't have improved survival compared to patients who have normal systolic blood pressures. So there comes a point where you've raised the pressure enough and you don't need to raise it more. In fact, you don't want to raise it more, because the higher the pressure, the more literally pressure you're putting on these new clots that are forming, and they could pop, and then you've just defeated the whole point of the resuscitation. I'll say that patients with traumatic brain injury are different, and they need a higher pressure. So we know that. So we don't need to increase the blood pressure very much. And two, I mean, you've seen what patients look like after an aggressive resuscitation with saline. The next day, if they're alive, they look like the Michelin Man. Like, they're puffy, their guts are hanging out because they're edematous. You can't close that abdomen. And what good have you done? I mean, all right, so the patients live to the next day so that they can die of sepsis. Well, that's terrible. That's not a good reason to be giving saline. In fact, when you look at the U.S. Military, the Tactical Combat Casualty Care, TCCC, and the Joint Trauma Service, JTS guidelines have completely eliminated crystalloid from the order of battle, if you will. It's all about the blood products. And so, maybe if you see, your helicopter coming, and there's blood on the helicopter, and you've just got to get the patient through till the helicopter can land, maybe a little touch, maybe no touch of crystalloid, because the blood's coming. That's the best fluid to give, and really you're not doing your patient any favor by very transiently raising the blood pressure. You give the normal saline, and within 20 minutes, 30 minutes, 2/3 of that is out of the vessel. And when it's out of the vessel, it's not helping raise the blood pressure, which was your goal. You said the patient you couldn't even get a systolic pressure, so you're trying to raise it a bit to keep up the perfusion. But 20 minutes later, the effect is over. And then you're left with the negative effect of the acidity you've created, and the edema. Oh, and the other beautiful thing is I don't know what the labeling of Ringer's lactate in Australia looks like, but if you look at the bag of Ringer's lactate in the US, it says, do not use in patients who are in lactic acidosis. Well, show me a trauma patient who isn't acidotic, right?
Yeah.
So the bag is telling you, put me back on the shelf and give me to somebody, in who's got sunstroke or sepsis maybe. Just don't use me for what you're going to do with me. So it's not advisable to use crystalloid. We know that, it's passé, and it's been passé for a long time. There was an excellent study, I think, a randomized controlled trial in Chicago in the 90s. And I'm just blanking on the name of the study. I know you guys know. It's embarrassing that I've forgotten. And they randomized patients to get aggressive crystalloid resuscitation early. So when you guys got there, you were pumping them full of ringers. And then the other patients were randomized to get all that fluid when they got to the hospital. And the randomization worked really well. The patients who were randomized for the early intervention had an awful lot more, they received a lot more crystalloid compared to the other group. And guess what? The group that had a lot more saline also had increased mortality. Exactly. And so Bickle study. This is So this has been known for years, but it's the way it goes in the literature is, a landmark study comes out and we read it and we think, I will implement this in 40 more years.
Yeah.
There was a landmark study in Transfusion about intensive care patients and what is the hemoglobin threshold that we need to use for intensive care patients, called the TRIC trial from like 1999. So it came out in 1999, New England Journal, respected authors, respected method. It was a really good study, and it took us probably 15 years to actually implement that. And so, to all the people who think that we need a randomized trial to implement whole blood versus components, I say, even if we did, it's going to take 15 years to implement that. So why not just go with what makes sense, what has been shown to be equally as safe, certainly not worse in terms of outcomes than components, and easy to give. That makes sense to me. And so I would leave the crystalloid on the shelf, and I would take the whole blood, and I wouldn't give it to that Brucey victim.
It's one thing we have to say. Obviously, everybody has their own ambulance service guidelines which they need to follow and adhere to. But certainly, the advice from the specialist is that withholding on the crystalloids is the way to go. And obviously, a lot of ambulance services need to look at the availability of blood in the pre-hospital environment. So we take that on board very much, Mark. Thanks for that.
But maybe they could go to their local CPG development team and say, "I listened to this podcast the other day with Professor Yazer, and surely it's time we bin the normal saline." That's fascinating stuff, Mark. And so what that Bickle trial comes out in 1994, we're here now, like 30 plus years later, and it's still being given as part of guidelines. And sort of from a research ethics point of view, what are your thoughts on sort of comparing blood or plasma, whatever's happened, to saline when that's a known harm? Like it should be compared to something that's not harmful and see if they do better. But
if something isn't working and it's actually doing harm, why would you keep doing it? If your bowler isn't taking the wicket, why would you keep bowling him over after over? I mean, look, if I knew anything about the Aussie rules, I'd make those analogies, but I know that's mayhem, man. I tried watching a game once and I was like, someone knows the rules and it's not me.
Yeah.
But Yeah, if we know better, we should do better. And I think we owe it to our patients to do the best that we can. And it's true, we don't have yet a randomized controlled trial showing the superiority of whole blood to components. There are two trials, the SWIFT trial and the Tower trial, that had similar designs to PAMPer, where they randomized pre-hospital injured patients to get whole blood versus standard of care. And they're going to be coming out very soon. But regardless of what they show, unless there's a signal of adverse event, unless there's some suggestion that the whole blood is making things worse, it just makes such intuitive sense to provide the patient with what they're bleeding. And we can discuss, should you bring plasma and red cell, or should you bring whole blood, or some variation of this. But again, as long as we're talking about providing blood products, I think we've made the evidence-based leap to improve patient care already, which again is what the TCCC and the JTS guidelines are telling us to do, is to leave the crystalloid at home and bring some kind of blood product forward.
Yeah, that's it's really interesting, because obviously I know from where you are in Pittsburgh there that you can't have blood on every ambulance vehicle, because obviously that's not feasible in any way, stretch of the imagination at all. And the way that I believe you, from memory, you have it set up, you had a couple of vehicles that worked in Pittsburgh that have the blood on the product, which services the area. We have a similar sort of thing here in Victoria, where we have blood on our helicopters. We have blood available to respond from the helicopter base by road, but we also have that availability of organising blood from a hospital at short notice with a phone call, and someone will go and collect it. But obviously those things take a bit more time to actually happen. Transporting the blood, what do you use over there in Pittsburgh? How do you carry the blood around, and how is the temperature controlled? How is the data recorded about the temperature of the blood controlled? Do you throw many units away? Is there much wastage? And yeah.
Yeah, funny you mentioned temperature. The temperature tonight isn't too bad, but on Sunday it's going to be about minus 30 Celsius with the wind. So yeah, normally we're trying to keep the products cool. Now we're going to try to keep them a little warmer. Yeah, but we have a couple of ways to bring the blood pre-hospital. In the helicopter, we used a very high-tech technology of picnic coolers. Because they work great. They'll keep your egg salad cool, they'll keep your red cells, or better yet, whole blood cool. And, don't forget always that the ice goes on top of the blood product, because what you really need is the air temperature to be cool. You're not really cooling the product itself, you're cooling the air. So if you put the beer or the blood on top of the ice, then it actually nullifies the effect. The bottom of the red cells are going to get really cold, and the air will be ambient temperature quick. So that's just a thing to remember. So yeah, so helicopters have the high-tech cooler, and as you say, we have two of these massive rescue vehicles, and I don't know the name, which should on a show called Pre-Hospital Nerds. But they're these big, they look like fire trucks, but they're ambulances. And they have actually built-in military-grade coolers that are powered by the electricity of the truck itself. And they're so good that even if the power is cut, the cooler can maintain the cool temperature, the valid the temperature for a long enough period for the time to get back to someplace where you can put this back in the refrigerator. So nothing wrong with low-tech coolers. You just have to validate it, put some ice in there or some coolant, and you're done. We like to keep the blood in those big rescue ambulance things because that's where we're going to need it. And it's monitored too. It has a cool Bluetooth connection or Wi-Fi connection that you can check. You can look it up and see what's the temperature of your board. And if there's a violation, an alarm goes off and someone will deal with it. And so it's pretty low tech, but the keys are just to make sure it's validated and that it works for a long enough period of time that you can do most of your missions with the assurance that the temperature is correct.
Yeah, good. I must say, I've been watching the show The Pit, and That's huge over here. It's fantastic, and I actually
Is it
been
really? Yeah.
learning. I blame Alex for it as well. He got me onto it, and I've been
Yeah.
watching it religiously, and actually not getting much sleep because of it. So I expect to see that blood vehicles put on the show in the pit, and you doing a cameo in there if you could, mate. If you can organise that as a blood expert and going, because they seem to have it on tap pretty much in that show. It seems to be coming from absolutely everywhere. So a great little
It's pretty cool, eh? I mean, it's awesome to see my city like known around the world, and not just for disgusting smog from the 1940s when we made a lot of steel. Yeah, it's really cool, and yeah, I wish they would have asked me for a little bit of help during that show they did on mass casualty, because
Yeah.
we really don't recommend strapping an empty blood bag to your boot and donating as you're operating.
Yeah, that's right.
It's a bit of Hollywood thing, and but it was cool because they had some stuff really right, like about using Rh positive transfusions for women, and they're big fans of whole blood, because that hospital there on which it's based is one of our big whole blood users in the city, and so it's written by one of the Emerge docs there, and so he uses his experience with our wicked whole blood to bring it in the show. So every time they mention it, it's like, yeah, get in whole blood.
I think they could have also used some of your drone footage. If you go to your Instagram, which we'll put a link to in the end of this presentation, that you've got some great drone footage over the river there as well, with the rivers freezing over and all that sort of stuff too. So yeah, they could have been able to use that as well as your knowledge. Fantastic stuff.
Hey, listen, Yazer Design Studio is always available for drone flying anytime that necessary. Contact me through Instagram. We'll give you a discount if you mention the podcast on the rates. Always looking for a new revenue stream.
Yeah, absolutely.
Thanks, Matt.
Yeah, well, speaking of drones and Yazer studios and all this, and then we spoke just before about the issues of storage and getting it out and cooling and stuff. What about one centralized place where all this was stored in Professor Yates's backyard with drone delivery? Anyone needs blood, pick up the phone, ring Mark, he'll drone it out to you. Possible challenges, too costly, too high tech? What's the situation with drone delivered
Nope.
pre-hospital blood?
It's doable. There are commercial companies that have done very successful drone implementations around the country. I think University of Michigan has a really successful program of this, and it's really cool. They use it primarily to bring laboratory samples from outlying hospitals to the main hospital, and it's all automated. The drones are like big, things not like the dinky little things I use, and they fly a programmed route, and they'll drop the sample down, and they are validated. Some of them are validated for carrying blood products, and so we've had a little foray into that with one of the companies. We've had some preliminary discussions with them, because it would be really cool to be able to do that. There's more limitations than you think. Maybe in Victoria it's not so bad, but here we have icing conditions, and I know you don't know what that is outside of like a mojito or like a Coke or something. But if there's visible moisture and the dew point is below zero, then it's difficult for these things to fly around because they don't de-ice particularly well. And so in some conditions it just wouldn't work. But there are laws that are designed for these sort of applications of the drones, and it's coming. I mean, if in 10 years we're not doing this, then we've done something wrong. But yeah, it's cool, Alex, and it's definitely coming. And they have such a great range too. These drones, even when they're carrying a couple of units, that it's not going to put you guys out of business, because a drone can't exactly do a finger thoracotomy yet. But it does have propeller blades, though. But it's going to be able to bring stuff and take samples around, and yeah, it's the future. I can't wait.
Yeah. Nice.
Yeah, nice one.
So, in preparation for this, we use our the resources available to us, ChatGPT being one of those, and it threw up some questions about some myths that are common out there in the environment, the pre-hospital environment. And one of them is about why worry about getting blood to the scene when it's probably just quicker to take the patient to hospital, you know, and that's probably one of the old mindsets of don't worry about giving blood, just put them on the bed and bring them to hospital. What would you have to say about that? Is there, you know, how much time do you feel would make a difference? Like if you're 5 minutes down the road, clearly waiting for blood, it seems a bit silly. But what sort of time frame do you reckon having blood immediately available is going to be more beneficial than just putting the bed on the patient and moving towards hospital?
So, yes, I think the first point is that you would never delay a patient's transport to definitive care waiting for blood. That's you need to get to a stitch quick, and you wouldn't delay or cause a delay waiting for transfusion. So that I think that's pretty clear. We actually have data on this, Matt, and another sub-analysis of the PAMPer trial. There was actually another randomized plasma trial at a single center called the Combat study, and we put PAMPer and Combat together. And what we found was that if the transport time is greater than 20 minutes, then there's a beneficial survival effect to giving plasma. So 20 minutes seems to be the critical transport time, at least for plasma. And of course, whole blood has a unit of plasma in it, so I think it's reasonable to extrapolate that to whole blood as well. But transport time isn't the only thing. Like, for example, God forbid there's a tactical situation and a policeman is shot in front of the hospital. Let's say right in front of the pit. He's shot right in front, which actually could happen because it's not in a great part of town. But maybe you can't get to that officer because there's still gunfire. And even though the transport time is going to be 30 seconds, once you're able to get to the patient, if he or she is down for a while and bleeding, then I think at least starting the transfusion while you're bringing the patient to the definitive care is a reasonable thing to do. So transport time is really only the last mile, kilometer, of care. You need to think about the entirety of the care. How long has that patient been pinned under the tractor, or been washed up on the beach, or something? And so, yeah, I understand that getting to definitive care is important. It clearly is the number one goal of pre-hospital care, is get them to hospital. But it ignores some of the obvious confounders, like how long has that patient been down and bleeding for? So I think to people who say, yeah, we've got a 10-minute transport time, that's great, but what was the injury to the injury time, and how long did that take? So I think having blood available for those situations, as long as it doesn't delay the arrival at the hospital, is a perfectly reasonable thing.
Yeah.
And as soon as they hit the door in ED, very few will get blood within 10 minutes. Obviously, sometimes if it's critical and we've been pre-notified and such, we could probably achieve it. But if they're reasonable, if you're saying sort of 20 minutes is the mark for when they start to benefit, if it exceeds 20 minutes, by the time they get in and registered and moved across and onto the bed and a second line put in, and 20 minutes is up. So,
one of the criteria for being a level 1 trauma center in the U.S. is having uncross-matched blood available in the emergency.
Yeah. And
I just, every time I hear the story about, well, we have fast transport times, so we don't need pre-hospital blood, I think, well, maybe you don't need the pre-hospital, or you don't need the refrigerator in your emergency room, because they're going to come so quickly you can get it from the blood bank. Now, obviously, that's not what I mean, but your point, Alex, is if they're just going to get blood when they hit the door, why not give it to them even 10 minutes earlier?
Yeah. Yeah, and I'd make intuitive sense. It's not the bricks that saves people. It's nothing magical on the other side. So. Good. You have some more myths there, Shep?
Yeah. So this is one that, we have to, when you get blood administration and you're allowed to administer blood in the pre-hospital environment, they put you through some training so that you get familiar with the type of reactions people can have to blood. Now, you addressed this when you spoke in Taiwan about, well, how do you recognise it? But Commonly, what sort of things for the novice administrator of blood in the pre-hospital environment? What sort of things can you expect with regards to reactions to blood administration?
Honestly, nothing. Um, because
Right.
you're so busy doing other stuff, and the most common types of transfusion reactions are so mild that you're probably not going to see any reactions. But let's be academic about this, shall we? So the two most common transfusion reactions are mild allergic, which is really the same thing as any other allergic reaction that you've ever had, which is you get some spots, some hives, you might get itchy, but there's nothing else. You don't have respiratory compromise, stridor or wheezing, vaso swelling of the eyes, lips, or tongue,
Yep.
angioedema.
Yep.
It's all stable, and the truth is, I don't know how naked you can get the patient pre-hospital, but if they're not trauma naked, you might not even see the rash,
Mm.
and so 1% of transfusions end up in a mild allergic reaction, and if you're using whole blood, I think that number is probably even higher because of the plasma. There's a very significant amount of plasma in the whole blood. Um, but even if you do see it, even if you get the patient naked and you see a few rashes developing, was that to your anesthetic? Was it to the
Yeah.
pain control? Was it to the transfusion? And the truth is, if it's just a rash and the vital signs, which are going to be obviously highly unstable anyway, but if they're stably unstable and they're not becoming more dyspneic and you're not having more difficulty aerating them, then just keep going.
Mm.
You literally keep going, because if you stop the transfusion, you're stopping a life-saving intervention for a very mild and non-life-threatening problem. If you see the rash that develops and then the patient starts swelling up in the eyes and tongue, and you're finding it harder to oxygenate, and you're thinking they're skating towards, by the way, skating means on ice with blades, in case you don't know what it's
Yeah.
from.
Yeah.
But
Thanks,
if you're
mate.
skating towards an anaphylactic reaction, then yeah, okay. I mean, that's a very serious reaction. You need to stop the transfusion, because now the harm outweighs the benefit, and you need to
Yep.
treat that. So that's mild allergic reaction. The other one is called a febrile non-hemolytic reaction, and it's caused by cytokines that accumulate in the unit. It most commonly happens in platelets, because platelets we keep at room temperature, and so the white cells are a little more active at room temperature, and they elaborate, the alphabet soup of cytokines that can cause this problem. It can't happen to whole blood, and it can't happen even to leukoreduced red cells, but it's less common, and it's manifested by, guess what? A fever. And
Mm.
wouldn't you love to have a fever in a trauma patient? Wouldn't that be just so wonderful to not be hypothermic? To be able to take one of the triad or the diamond of death away because they're having a febrile. Now I'm being a bit flippant, but it is possible that you might notice a fever if you're monitoring the temperature, and if you happen to notice it. And again, I would say, if the patient is otherwise stable, and they're having a little bit of a fever, then carry on with it. What you want to be concerned about, or the main element to be worried about if a patient starts having a fever in association with a transfusion, is, are they becoming septic from a septic transfusion? So was there some bacteria in that unit that's now in the patient, and the fever is the manifestation of sepsis? And of course, in a hypotensive patient who's tachycardic, it's going to be difficult to tell. They're probably cool and clammy anyway because they're bleeding, and so
Mm.
don't ask me how to tell if they're septic. That's your job. But that's the thing to have in your mind is, am I seeing this fever because it's just a fever, or is it a harbinger of sepsis? And if you think it is sepsis because they're becoming more unstable and more hypoxic, then yeah, stop it. But the number of transfusion reactions that we see reported from the trauma bay, and frankly from the OR, is so much smaller than the number we see from the outpatient hematology clinic, where there's
Yeah.
a nurse for every patient, and they're scrutinizing everything, and they're looking for hives. And so no doubt trauma patients are having these these mild reactions. But the truth is, in most cases, who cares? The transfusion is so much more important than stopping it because they're getting a little itchy. I would just carry on. Volume overload. Wouldn't you love to have a volume overload in your helicopter? Right? Wouldn't that be like a happy day? Because the vasculature is now intact, they're not bleeding, and the transfusion is just ending up in their lungs because of all the pressure. So volume overload, probably not. Transfusion-related associated lung injury. Again, I don't know in Australia, but here in North America, the dentist years ago insisted on having fluoride in the water to make everyone's teeth stronger. But if you think about it, they should have put like sugar in the water, right? Because sugar, tooth decay, more business for the dentist, right? And Trolly is like the same thing. Like when we discovered Trolly, which is a really rare complication caused generally by leukocyte antibodies from the donor that bind to neutrophils of the recipient, and the neutrophils end up in the lung, and the patient ends up with really a hard time oxygenating. When we discovered this disease, we in the transfusion community it was like headline news, and every time a patient had a hiccup during a transfusion, we were like, could be a Trolly. And so we've really put the fear of Trolly into everyone who transfuses, even though we've done a lot of things to prevent Trolly from happening, in particular by excluding donors who are likely to have these antibodies. And so Trolly, very rare disease, very, very rare. And even in a couple of hours of helicopter time, I guess it's possible you could see a Trolly, but I think Australian Blood Services also excludes the donors who are most likely to have these antibodies. And so it's a really rare thing, really unlikely. And hemolysis, again, very unlikely to happen because you're using products that are universally compatible, group O, whole blood, low titer of the anti-A, anti-B. Could it happen? Sure. Could you tell? Probably not, because how do you tell if a patient's hemolyzing? They have red urine. Well, that's probably going to happen anyway. They're hypotensive. They might have a fever. And the biochemical changes, which you don't have in pre-hospital, are identical to the changes that happen in trauma anyway, when tissue just gets, fried and destroyed. So it's really hard to tell if a patient's going to hemolyze. And we as a community have taken great steps to reduce the risk of hemolysis, just like we have for Trolly. So, there are a number of reactions. Most of the common ones are ultra mild, and in most cases wouldn't warrant stopping it to deal with a bit of a rash or fever.
So the long and the short of that is, unless they're having a full-blown anaphylactic reaction, push on.
Yeah, if you want to call the base and get some advice about what to do, one thing you can do with a transfusion is you can always pause it. You can always just clamp it and leave it attached to the patient, and then call someone to get some advice about what to do. In particular, if you think the patient is headed towards something a bit more severe, you don't have to stop and disconnect the transfusion. You can always just leave it attached without infusing, and that way, if the advices crack on, then you can just take the clamp off and go back to it. Whereas if you've taken it out and taken it down, it's going to be harder to restart that unit.
Yep.
So, and I think the overriding message that I always give to people who are transfusing is, if you think there's a problem with the transfusion or caused by the transfusion, then stop it. Get some advice, and then see what the advice is to crack on or not. But again, in most cases, you're not going to see a problem that's worth stopping outright the transfusion. You certainly wouldn't do it just for hives. But if it turns into something worse, yeah, definitely. You don't want to make things worse, trying to make things better.
Good. I'm being very mindful of the time. We're up to around 49 minutes already. I reckon we could chat for hours. Alex, one more question for Mark, if you could, mate. What have you got sitting on the tip of your tongue there?
Oh, so much. But first we must point out that beautiful jumper you're wearing, Mark. But could we please send you one of the brand new shirts as well? You could have that under, but tell us about this jumper. That's a favourite soccer team, is it?
No.
No? Oh, that's the...
Cricket, mate. Even
that's
I
behind you.
recognise
That's
that,
the
mate.
cricket. Yeah. I'm not from here. There you go.
Yeah, I wore it just in case the conversation was a little dry, and I thought you could insult me over and over about the ashes being a palm. But as I quickly learned, Matt doesn't know a bat from a ball.
Was that a baseball you
And
was holding up?
Yeah, exactly. It's a baseball, right? Yeah, classic six-seam American baseball. It doesn't know a run out from a stumping. Go figure. But yeah, I'd love to have the T-shirt. I'll wear it. Absolutely.
Yeah. Now we'll have to get that shipped across. Hey, maybe I could then ask a question around the sort of research side of things. So, we've spoken about which patients go into these trials and what's good to compare. It's sort of, is it whole blood or component versus saline or all the harmful stuff. But what do you think on the outcome? Every trial's got a set of primary outcome. What are we trying to fix with this blood? And like mortality at 6 months, a month, like 4 weeks, is a unit of blood sort of going to be judged on that pre-hospitally? Is it better to sort of have survival to hospital, but then people say, well, that doesn't really matter for the patient where they ultimately die, so that's not a good outcome. And just, it's fascinating, across all the trials out there, they seem to pick very many different research outcome from the sort of blood pressure at 3 hours to, the patch trial that we did down here on TXA, the primary outcome was like 6 months, functional outcome at 6 months. Now, surprise, a gram of TXA pre-hospital did not impact that because there's hundreds of things that go into someone's recovery. And what's the ideal primary outcome?
So there was a really nice consensus paper published on this topic a couple of years ago, and I think it makes a lot of sense to say that the outcome for an intervention that's meant to deal with something that's happening right at the beginning of the resuscitation is 4 to 6 hours survival. Because if you think about it, the most common cause of death in trauma at 12 hours, up to 12 hours, is bleeding, because it's a quick way to die. And if you survive the bleeding part of it, then maybe you'll die from brain injury. And if you don't die from brain injury, then maybe it'll be multi-organ failure or sepsis. And so what you're saying is exactly right, is it's really not fair to blame a death at 14 days after the transfusion on that transfusion, or to say that that transfusion could have prevented that death 2 weeks later, when really transfusion was successful in doing its job of getting the patient through that first 4 to 6 hours. And so I think, when a patient's bleeding and you're trying to stop the bleeding and reverse the shock, then that's all really early on. And so I think 4 to 6 hours is the most reasonable time to expect to see a difference when you're performing any trial of a hemostatic product.
Yeah, great. No, that's interesting. Yeah, because if you look at the sort of triad of death, or when the trimodal distribution of when people die after trauma, it's sort of either immediately, and transfusion is not going to do anything for those that have an issue there, or it's in that sort of 12-hour, the first half day, as you mentioned, or it's a few weeks later in ICU from multi-organ failure. And yeah, no, I'd love to see more trials focusing their primary outcome on that middle section where it actually makes sense that it could have a positive impact.
There we go. A collaboration paper for the future, perhaps. Now, so
great idea.
I think we need to wrap it up because obviously we're getting towards an hour there, so that's quite lengthy. So thank you, Mark. Mate, I definitely want to see if we can organise to get you out here to Australia, because I think a lot of people would love to listen to you, what you have to deliver. Certainly I experienced it when I was in Taiwan, so I will do some background work and see if I can get you involved in one of our conferences that we've got here later in September in Australia, and it's in Melbourne this year, so that would be even better because then we can get you to a footy game and we can teach you.
Explain the rules to me.
Yeah, absolutely. The rules are, there are no rules, mate. That's pretty much it. But mate, we really appreciate you. I think it's late at night for you over there. Is it 10 o'clock or something like that now? So
Nah, it's like 8:30. So
so it's past your
just
bedtime. Yeah.
yes, yeah, it is. Yeah, I'm on fumes.
Yeah. Mate, we really do appreciate your time and your knowledge and sharing your experiences with us. So thank you very much from the pre-hospital nerds. One thing that we're trying to encourage any of our guests to do is to provide a little dance for us. So I'm going to get that out of you in a moment.
Let's see a dance.
Yeah, we need to see it, mate. We need to see those moves.
Want to see a little song and dance?
We need to see it.
Yeah,
Now you asked for it. Hold on.
Hold on,
I'm
here we go.
gonna get my dance partner, and
This will be the cat. Yeah, there we go.
everybody dance now.
Excellent.
Oh yeah. So
Perfect.
Ramsey
That's one
says
in the-
hello.
That is going in the intro video. Thank you very much, Mark.
It's splendid.
Get down.
Yeah.
You know, my
thanks everyone for
dancing is
listening.
like
Oh, you
brownie in motion. Like people bump into me, I move. That's like how I dance. I'm not that great, as you saw.
All good. Thank you very much,
We
Mark.
should encourage everyone to donate blood.
Yes,
No,
we
it's
should,
it.
yeah.
All this talk depends on people actually donating.
Great message. And thank you so much for inviting me. It's such a great cross specialty moment for me, and I really appreciate that you invited me on the podcast, and I really enjoyed this chat. Thanks again, guys. Cheers.
Yeah.
Wonderful.
Thank
Thank you very much.
Good day.
Thank you.